I'm sure everyone's gonna enjoy this thoroughly. All over to you for the next hour or so.
Okay. Thank you for the
Uh,
kind introduction. So I'll just share my screen to start with.
yeah, sure.
Is my screen visible?
Yeah, it is visible. Lovely.
Yeah.
All over to you.
Thank you. So very good Saturday evening to everyone. I am Dr. Neeti Gupta. And firstly, I would like to thank the organizers for inviting me to speak at this amazing platform that has been consistently spreading knowledge since so many years. Today, I'll be discussing some cases of pediatric MSK trauma, through which I will be highlighting some important differences between pediatric and adult trauma patterns. I hope you all gain some helpful insight from this today's talk. So, let's just start with the first, the cortical outlines. So you in order to avoid missing it. So this is classically caused due to an axial compressing force on long bones, and pediatric bones being soft do not fracture in a similar pattern to adult bones. They usually have more plasticity, and that's why they either bow or there are these subtle cortical fractures which are incomplete fractures, and these are called torus or buccal fractures. So this was a subtle case, and those who found it in the first go, kudos to you because I hadn't found it in the first go. Okay. So similarly, there are some other fracture types that are characteristic of the growing skeleton. And these occur mainly because the pediatric bones are soft, as I said, and they tend to break in a different pattern as compared to adults. They initially tend to bow, and depending on the type of the force, they either break on the convex side or the concave side. In a green stick injury, there is an element of bowing in addition to the fracture because usually the bone bows, and then finally it gives way, and there is an incomplete fracture on the convex side of the bone. So this is how pediatric bones fracture. Now, while evaluating any radiograph, it might be helpful to follow a certain approach, such as the ABCS approach, which I usually follow, in which I check if we have all the appropriate and adequate views. By appropriate views, I mean that the part that is painful should be covered adequately, and adequate views, as in we have at least two orthogonal planes of the long bone. And in cases of hand, wrist, or other complex joints, we can take additional oblique views so that we can have a comprehensive evaluation. Then we come to the bone alignment and we see if there is any change in the bone alignment. After which we trace all the bony cortices, as I showed you the importance in the previous case, to look for any subtle step offs or cortical breaks. And finally, we look at the soft tissues to look for any soft tissue swelling or displacement of fat planes, which may prove helpful in certain cases. In fact, soft tissues are proved to be very helpful in certain cases. And Dr. Ravi Ramakantan sir told us repeatedly in his classes on radiographs that there is no smoke without fire. Similarly, there is no soft tissue swelling without any underlying cause. So the presence of soft tissue swelling in any particular area should be looked at closely for any underlying bony pathology. Now, here is the next case of a 5-year-old child with a history of a fall on outstretched hand. Please post your findings in the chat box and we'll discuss this case quickly. Okay, so many of you are getting this correct. I'm happy to see that. Okay, so what we are seeing in this case is classical sail sign. Now, what is the sail sign? We are seeing elevation of the anterior fat pad and we are seeing elevated posterior fat pad. Now we have seen elevation of the fat pads which indicates joint effusion. So if there is joint effusion, there has to be some intra-articular fracture. If you see, there is the subtle cortical buckling on this side. And another important point is if we draw a line along the anterior humeral shaft, we see that it is not transecting through the capitellum in any way. So this is the anterior humeral line and it is not transecting through the capitellum, which means that there is some posterior displacement or tilting of the humeral condyles. So yes, those who answered supracondylar fracture of the humerus, you're right. And so let's see how to evaluate a radiograph of the pediatric elbow. So there are four important points to be evaluated. Firstly, like I showed, the presence of elevation of these fat pads, anterior and posterior fat pads. So remember that in the normal elbow, if you see, the posterior fat pad is not normally visible because it is inside the intercondylar notch of the humerus. So it is not normally visible. When it is visible, it is pathological. It means that there is some joint effusion which is pushing out this fat pad posteriorly. And an anterior fat pad is normally visualized, but when it looks like the sail of a ship, it means that it is elevated, again indicating joint effusion. So, in the history of fall in a pediatric patient, if you're getting joint effusion, it indicates hemarthrosis. Now, hemarthrosis would occur due to an intra-articular fracture. So, your next aim will be to localize the fracture. So the second point to look at is the radiocapitellar line, in which you draw a line along the middle of the radial neck, which should pass through the center of the capitellum. If it doesn't, it raises a possibility of radial dislocation. So I already showed you the anterior humeral line, which should intersect through the middle of the capitellum. If it intersects through the anterior third or anterior to the capitellum, sorry, it indicates that there is a posterior tilt and there is a high possibility of a supracondylar fracture. The last point to evaluate is the presence and position of the secondary ossification centers of the elbow with the help of this popular mnemonic. So, absence of any particular ossification center can raise a possibility of a displaced fracture. Now, in any case, if all these 4 points also don't help you, there is still some doubt, you can always compare with the contralateral side. That will again give you a further clue. Now, it is important to remember that there is normally a lucent gap between the secondary ossification center of the lateral epicondyle of humerus and the lateral humeral condyle due to the presence of intervening cartilage, whereas the medial epicondyle is closely opposed to the medial condyle. This is important to remember so that we do not mistake this appearance as a fracture of the lateral condyle. So this is a common pitfall in the pediatric elbow, which you must remember. Now coming to the next case, we clearly see this fracture line in the distal tibial epiphysis extending from the articular surface to the physeal plate. So this is, of course, a Salter-Harris type 3 fracture. In this location, it is known as a Taylor fracture. Now, in the same case, we look at this lateral view. Are you able to appreciate this subtle fracture line involving the posterior tibial metaphysis, which is extending up to the distal tibial physeal plate? So this will qualify for a Salter-Harris 2 type fracture. But when both these fractures are seen in the same case, This indicates a triplane fracture. So this is essentially a Salter-Harris type 4 fracture. I will not be elaborating too much on the Salter-Harris classification because it plays more of a descriptive role rather than prognostic. And the Salter-Harris type is not strongly related to the prognosis. Prognosis is more associated with the area of injury, that is, in areas of higher growth rate. Um, Injuries of the fascial plate will more likely result in complications. So my main aim of this case was to emphasize on the point that one view is no view. You have to look at the AP, lateral, and in addition to that, oblique views is if required. Coming to the next case of an 8-year-old aspiring football player who came with complaints of medial knee pain and tenderness. Now, I won't be waiting for answers. I will just give out the answer on this one. We are seeing this irregularity and widening of the proximal tibial epiphysis with some sclerosis on the metaphyseal side. These indicate a chronic fascial stress injury, a chronic fascial repetitive overuse injury. So, the orthopedician actually wanted to rule out osteomyelitis because there was a lot of soft tissue swelling associated. So, the child was actually referred for an MRI. The MR images also showed the same findings as the radiographs. That is fascial widening, some sclerosis on the metaphyseal side of the fascial plate, fascial edema, hyperintensity, and widening. We do not see any signs of osteomyelitis. The metaphyseal marrow is absolutely normal, as is rest of the marrow. So we told the orthopedician that there is no osteomyelitis. There were changes of cellulitis, but those were because of a recent overlying soft tissue injury. But we ruled out osteomyelitis, and after taking history, the child had pain since birth, pointed towards a chronic fascial stress injury, as he was a football player, like I said earlier. Now let's see how the growing skeleton differs from adults. The main differentiating feature is the presence of these cartilaginous plates, which are the weakest and most prone to injuries, especially at the time of growth spurts. There are two types of epiphysis in the developing skeleton: the pressure epiphysis and the traction epiphysis, which are also called as apophysis. So the pressure epiphysis contribute to the longitudinal growth of long bones and they form joints, whereas the traction apophysis or epiphysis are non-weight bearing, found at tendon and ligament attachments, and do not contribute to joint formation. So I will show you another case. The joints are all normal. There is mild ulnar, negative ulnar variance, but other than that, we do not see any signs of injury. Now coming to the MRI of the same patient. At the first look, it appears normal. However, if we scroll dorsally, this is ventral, there is a small ganglion cyst here, but that is not the cause of pain. It's an incidental finding. Coming dorsally, we see another tiny ganglion cyst. But in addition to that, sorry, there is some problem with the. Are you not able to see my?
No, uh, we can't see the uh, cases, I think. Let me just figure out what's the issue. Can you just share again?
I'll just share this again. Sorry for that. Is it visible now?
Yeah, we can see the MRI.
Is it seen properly,
Yes,
clearly?
yes.
Do I need to repeat the CT as well?
Uh,
Anyway, the CT was normal, so I will not be showing that again. I just wanted to show you that it was normal. And on the MRI, as I was saying, at first dorsally, we see this tiny ganglion cyst, but again, this was not the cause of pain. What we see in addition to that is this mild edema and slight widening of the dorsal aspect of the distal radial physeal plate. If we see on the sagittal PD FATSAT images, again, we are able to appreciate. Can you see this mild subtle widening of the dorsal physeal plate? So this was actually a case of, again, a chronic overuse physeal stress injury in an athlete. So this is labeled as a gymnast wrist. In chronic physeal overuse injury in the distal radial physeal plate is labeled as a gymnast wrist. So I'll come back to my presentation. Sorry, I'll have to do that, switch in between.
uh, can you try Command and Tab, and you should be able to switch to the presentation quickly.
Yes, I'm trying to do
Yes.
that. Yeah. Is it visible now?
Yeah, yeah.
Hmm. So that was a case of gymnast wrist, and now we are coming to the next case. Now, what do you see here? This is a 12-year-old male child. So what do you think? Which side does he have thigh pain on, and why? Just give you half a minute. It's a subtle but a commonly seen case. Which side is the thigh pain on, and why? So most of you are getting this right. I'll quickly just tell you give you the explanation. So this is a classic case of a slip capital femoral epiphysis. As most of you guessed right, the pain is on the left side. So we can see some physeal widening and irregularity here when compared to the contralateral side. And in addition to that, if we draw a clean line along the lateral aspect of the femoral neck, normally it should intersect a portion of the lateral capital epiphysis, but here it is not intersecting at all, which indicates that there is some slippage of the femoral epiphysis. If we see here, it is normally intersecting the femoral epiphysis. But be careful, many of these cases are bilateral, so you might not always have the opposite side for comparison. So this line is more reliable, and always remember to evaluate the contralateral side. Now, we saw quite a few physeal plate injuries. Um, now, why are these injuries important? If we see that the vascular supply of the pediatric long bones is very peculiar, such that the supplying vessels do not cross the physeal plate in normal individuals. In case of physeal injury, neovascularization and vessels develop across this physeal plate, which can predispose to transphyseal bridging. Now, this is a classic example of a complication of neglected physeal injury. There is significant growth arrest of the distal radius with transphyseal bridging, as seen on this X-ray as well as MRI, with resultant significant positive ulnar variance. So this is why these physeal injuries need to be addressed and identified in the early stages so as to avoid these significant complications. And these physeal bars, they can lead to significant significant angulation and deformities as well as growth arrest, making early detection of these injuries crucial. So, facial bars, as seen in this case, they may be seen a few months after injury, but typically we see them almost a year after a facial injury. Now, in some cases, there can be interposition of the adjacent soft tissue into the widened facial plate, which can be suspected when there is persistent facial widening on follow-up radiographs. In this case, we can see the trapped posterior periosteum. If you see this curvilinear hypointense signal intensity, this is a trapped periosteum within the widened posterior femoral facial plate. So this trapped periosteum will not only also lead to predisposed to formation of transfacial bars as we saw earlier. That is because the pediatric periosteum has a strong osteogenic potential, and that's why it can lead to facial bridge or newborn formation across the physis. So it is important to suspect soft tissue interposition, especially when you see persistent facial widening in follow-up radiographs. Make sure to get an MRI in such cases. Then also, you also need to remember some pitfalls. Watch out for important pitfalls, especially like this bump or prominent undulation of the distal tibial facial plate, which should not be mistaken for a facial bar. It is the earliest site of facial closure in the distal tibial plate. Characteristic location like the distal tibia and distal femur and absence of adjacent marrow edema or soft tissue edema distinguish it from pathological facial bars. Now, these undulations, they say, are possibly there to stabilize the growth plate and prevent its displacement. But the presence of these undulations, unfortunately, increases the chances of transfacial bony bridging, mainly because of the increased surface area that is exposed to the injury. You can go through this really good article by Nguyen et al. For a detailed discussion on pediatric growth plate anatomy and pathologies. Coming to the next case, a 15-year-old badminton player with pain in the right gluteal region. So, do you see anything? 15-year-old badminton player with pain in the right gluteal region. The site of pain is your clue. Yeah, many of you are getting it right. Sorry. So at first look, the radiograph might look apparently normal, but with a chronic history of right-sided gluteal pain, you are not now able to appreciate this subtle cortical irregularity at the right ischial tuberosity. With the history of gluteal pain and these imaging findings, you should suspect an epiphyseal injury of the ischium at the common hamstring tendon origin. One of you said, commented as an avulsion fracture. So there is no displaced bony fragment here. So I would call it as epiphysitis rather than an avulsion fracture. Um, we also have MRI images of the same patient, which clearly show the presence of physeal widening and edema, suggesting epophysitis, which is again a chronic overuse injury, as we also saw in the previously in the physeal plate. This is an chronic overuse injury of the epophysis. So this is labeled as epophysitis. In addition to that, you may also see some tendinopathy in the tendon that attaches to the apophysis. Now, in adults, injuries caused by excessive tensile force on the muscle tendon bone unit tend to result in myotendinous injuries. But in skeletally immature patients, again, like I told you, the presence of these cartilaginous plates, they predispose children to different types of injuries, such as epiphyseal avulsion fractures, because this is the weakest biomechanical point in pediatric skeleton. So, in adults, you might see myotendinous injuries commonly, whereas in children, if there is pain, you suspect an avulsion fracture rather than a muscular or tendon injury. Now, to highlight the role of ultrasound, I would like to show you all this case of 14-year-old female athlete who came with complaints of pain in the right groin region. The pelvic radiograph elsewhere was reported as normal, and the child was referred for an ultrasound of the right hip. So I'll just skip to the ultrasound images. Now, on ultrasound, the hip itself was normal. So then I asked the patient, where exactly are you having pain? And she pointed to the site of ASIS. So I placed my probe there, and what I saw was this is the ASIS, a longitudinal view. So we are able to see some uncovering of the subchondral bone of the ASIS with this curvilinear fragment displayed slightly inferiorly, which is actually the apophysis of the ASIS. And there was some amount of neovascularization in that region. So this is the other side, the asymptomatic side for comparison, in which we see this curvilinear apophysis seen normally covering the underlying subchondral plate. So I gave the possibility of ASIS, epiphyseal avulsion injury. They also got an MRI confirmation, which confirmed the ultrasound findings. But you can see how subtle the MRI findings are in contrast to the ultrasound. A big added advantage of ultrasound, as we all know, is that it can be guided by the patient's symptoms. So, where she said, I have pain, you keep the probe, and many times you will see the abnormality there. And so, ultrasound can help to detect even minimal cartilage and bone abnormalities. So, in the absence of marrow edema and a chronic epiphyseal injury, findings can be really subtle, and you can always use ultrasound for correlation. Now, retrospectively, if we look at the pelvic radiograph again, we can see the subtle lucency in the region of the right ASIS without any displaced fracture fragment. So, just a brief overview of the role of ultrasound in apophyseal injuries. This is a normal ASIS apophysis in which we can see two hyperechoic structures. The uneven structure is the subchondral plate, and the smooth curved structure is the apophysis, which is seen normally overlapping the ASIS when it is not displaced. In case of injury, in this case, as we saw in the previous case, we can see the inferior displacement of the overlying apophysis and uncovering of the underlying subchondral plate. So sometimes this may also be associated with mild tendinopathy of the tendons inserting at the apophysitis with mild associated soft tissue edema. But these are the classical imaging findings of an apophyseal injury on ultrasound. Now here are two case scenarios, case number 1 and 2, with complaints of knee and shoulder pain respectively. Which do you think is normal? Which do you think is abnormal, or are both abnormal? What do you think? Which case is normal, which is pathological? Complaints of knee and shoulder pain. There are two different cases. Are you seeing an abnormality in the first case or the second or in both? Okay, now to make things easier, let me show you the contralateral radiographs. Now, what do you think? Which case is normal, which is abnormal, or are both abnormal? Okay, so I'm sure now you're able to appreciate this physeal widening in this proximal tibia. In case 2, we do not mistake this as a fracture line. This lucency is just superimposition of the posterior physeal plate. The view is a little cranially oriented, so do not mistake this for a fracture. And this is a normal appearance of an undulating physeal plate of the proximal humerus. If you can see, both sides are symmetrical. There is no asymmetry on either side. So this is essentially a normal X-ray, whereas here we see a physeal injury in the proximal tibia. So in case of doubt, you can always use contralateral radiographs for comparison. And sometimes I also use radiographs of age-matched patients from my database or from the internet for comparison. Comparison is a very valuable tool. Now coming to another scenario for which I get routine referrals, as we have a sports academy not far from our hospital. Complaints of low back pain in adolescent athletes. Now let's have a look at one case. I'm sorry, I'll be stopping this share and I'll quickly go to the other screen. Are you all able to see the images clearly? I'm showing you an MRI of the whole spine.
Yeah, Niti, we can see it.
Okay. So this is an adolescent athlete with complaints of low backache who was referred for a whole spine screening MRI. Now, if you look at the spine, it looks normal, right? But there are complaints of low backache, and it is very important to always look at the stir sequence as well. So now we are evaluating the stir sequence, sagittal stir. Now, what do we see here? We can see some amount of marrow edema here, the parasagittal section, which is at the level of the pars interarticularis. So I raised a possibility of a pars interarticularis fracture or stress injury or spondylolysis. And they got a CT done for this case. I'm scrolling through the actual CT images. Going cranially. Now, do you see the subtle linear lucency in the left pars interarticularis at the same level? this was a classic case of a stress injury at the left pars interarticularis. As you can see, it can be quite subtle on CT as well, but there is some definite sclerosis here in the pars interarticularis if you compare to the other level. And on axial, we were able to see that subtle lucency. So the point that I would like to highlight here is that in pediatric or adolescent athletes who are coming with low backache and you don't see anything on the sagittal T2 images of the spine, please go for a stir sequence and look for edema in the region of the pars interarticularis because that can provide a clue to a stress injury of the pars interarticularis or spondylolysis. So coming back to the presentation, now we are coming to another case of a 14-year-old girl who came with a history of a fall on outstretched hand. So what do you see here? Are you seeing any abnormality? After the fall, she is having pain in the ventrolateral aspect of the wrist. Yeah, I wanted one of you to say a distal radius fracture because that's what the orthopedician had suspected, a distal radius fracture. I'm also showing you all the MR images now. Okay. So these are the MRI images of the same patient. Now you can tell me what you suspect after looking at the MRI images. Are you still suspecting a distal radius fracture? Are you still suspecting a scapholunate injury? Or is the pathology elsewhere? So this is the ventral aspect of the wrist. I will also show you sagittal images, PD FATSAT. So this is the sagittal image at the level of the scaphoid. Yeah, so there is some edema here in the ventral aspect of the scaphoid. Okay, and after looking at the MRI, I was still not sure of what was happening, whether there was a tiny osteoid osteoma here or there was some injury. There was a proper history of fall on outstretched hand. We can see on the axial images as well, there is some edema in the ventral aspect of the scaphoid here. But I was not very sure of what was going on. So what I did was I went for an ultrasound, a focal ultrasound in that region. And these are the ultrasound images. So here we can see a double curvilinear shadow in the region of the scaphoid. And as we can see on the asymptomatic side, we do not see this double curvilinear shadow structure. And on the longitudinal images also, we are seeing these two lines, two linear areas. The FCR tendon is seen coursing over the scaphoid, And this is the distal tubercle of the scaphoid bone. Now, coming back to the radiograph, we are able to see this subtle small fracture of the distal scaphoid tubercle. So, in this case, the MRI and ultrasound both helped in diagnosing this fracture of the distal scaphoid tubercle, which was barely seen on the radiograph. In fact, I saw it retrospectively. Even I was focusing on the distal radius, but I was quite sure that this is a normal physeal plate which is still getting fused. So this is not a fracture. This is the fracture, and this was the cause of ventrolateral pain in the patient. So be careful. Always correlate various modalities when in case of doubt. And again, you can use the contralateral side for comparison. Now, a few other cases in which there is some difference in pediatric and adult pattern of injury. In pediatric knee twisting trauma, the most common type of injury is the ACL avulsion fracture. Here we are seeing an avulsion fracture of the spine, the intercondylar eminence, which is an ACL avulsion fracture. In adults, we commonly see ACL ligament tears in twisting injury, but because the pediatric ligaments are stronger as compared to the bones, which are softer, it leads to this type of injury. And very common, be careful when you're looking at any ACL injury because most probably it will be an ACL avulsion injury if it's a child. There is this classification suggested by Myers and McKeever, based on which the management is decided whether it will be conservative or operative. So this was a case of a 10-year-old child, a girl with pain in left knee. So we do see this benign lytic lesion in the distal femur in the metadiaphyseal region with a thin sclerotic rim. But do these cause pain? And what do you think is the cause of pain in this patient? Is the Okay, so this lesion is an FCD or no, more likely an FCD. But do you think this is the cause of pain or is there some other thing that is causing pain? Do these lesions itself cause pain? Yeah, now some of you are getting it right. So here are the MR images. Now, what do you think is the cause of pain? So this lesion was an FCD or fibrous cortical defect. But here on the radiographs, if you can see this sclerotic line traversing through the distal femoral shaft adjacent to this FCD, and there is some bowing, anterior bowing of the distal femur in this region. So this was a case of pathological fracture, stress fracture in the region of the FCD. In an underlying FCD, a pathological fracture, which was the cause of knee pain. Always remember that these benign lytic lesions are not generally painful unless there is a pathological fracture or there is some malignant transformation going on. Finally, just touching up on fracture healing. So, pediatric fracture healing follows the same process or steps as adults, just that it is a little faster. So, within just a few days, around in just 1 week, you might see florid callus formation in the reparative phase, which is a normal phenomenon. And because of the higher remodeling potential of bone in children, even though there is so much malalignment at the fracture at this time, they don't usually go for an open reduction because of the higher remodeling potential, the bone remodels itself, and generally in a few months or a few years, you will see that the bone looks as good as new. So there is a the orthopedicians take a higher the orthopedicians take a more conservative approach towards pediatric bone fractures because of the higher remodeling potential and a faster remodeling potential. The typical phases are same as seen in adults: inflammatory, reparative, and the remodeling phase. So when you're seeing the loosened fracture line, it is the inflammatory or the reparative phase. When you are seeing a hard or soft callus formation, you are in the reparative phase. And when the bone looks as good as new or it has remodeled, it is the remodeling or remodel phase. So, few things that I would like you to take away from this lecture are: first of all, optimize your imaging, optimize which modality you would like to look at, and the views on radiographs. I already discussed the ABCS approach on radiographs, and remember that there can be no soft tissue swelling in cases of trauma without an underlying bony injury, so there will be no smoke without fire. Pay attention to the physeal plates in pediatric age group. There can be subtle physeal injuries which may be occult on radiographs or CT, so you can get an MRI done or compare with the contralateral side in cases of doubt. Examine and talk to the patient. Most of the times you will get your answer there. Talk to the patient, examine the patient yourself, and go out of your reporting room, talk to the patient. They will point to the site of pain, come back, have a look at the images, maybe go for an corroborative ultrasound or a focus as required. And most of the times you will get your answer and the cause of pain. Do not settle with a normal report. The thing I fear the most is giving any report as normal, because I have to look 10 times to see if I'm not missing out on anything. In cases with unremitting pain, normal imaging, look twice, compare with the contralateral side, compare with another child of the same age. You can always Google up images of radiographs of the same age group child, and that will help you to come down to a diagnosis. So you can follow these steps in a child with trauma with localized pain and tenderness. If you look at one view and if it is apparently normal, maybe you're missing something. So you look at the other views. And if they are still normal but patient still has pain, go ahead with another modality. If it is normal, if one view is normal, the other views are also normal, you can also compare with the other side. And if there is any subtle abnormality, again, you can go ahead with other modalities to look for, to confirm and to characterize the injury further. If one view is showing you an obvious fracture, still look at the other views for accurate characterization and classification. So thank you very much for your attention, and I hope you have all learned something from this lecture.